Thank you, and thank you very much for the opportunity to talk again. It occurs to me that when I was given the title of this talk, Saying No, A Physician's Perspective, I'm obviously not very good at saying no, or I wouldn't be here tonight. But I thought I might give you some ideas on how to actually say no.
Oh, God in heaven, there are just so very many ways for me to say this to you. Never, not in a million years, absolutely not. No way, Jose, no chance, Lance, yeah, negatory, and of course my own personal favorite of all time, man falling off of a cliff. No! The next box.
So I have had a lot of training from television and scrubs. I'm going to give a very highly opinionated talk which has evolved over my experience running high-risk clinics over the last 15 years, and all of the opinions are my own and I accept full responsibility for them. What I'm going to tell you though is that saying no for me in my high-risk clinic is actually many shades of grey, possibly more than 50 shades of grey. I saw a couple of patients the other week that I thought I'd share with you. The first one was a woman who was sent to me by an ENT surgeon for repair of a pharyngeal pouch. She was in her 80s, she was pushed in a wheelchair by her daughter, and I just had that uneasy feeling that this was really not someone who was going to do well with surgery. Not because she was going to die, because I reckon my physician and surgical colleagues, anaesthetic and surgical colleagues, are actually pretty good at not killing people, but I thought she was actually going to be frail and unwell. So I recruited one of my dietitian colleagues, and it turned out that the daughter was actually feeding this woman a low-calorie diet, thinking this was what her mother needed. And so when we actually gave her a calorie-laden diet, she put on 5 kilos, felt much better, and we cancelled her surgery. The second woman I saw had actually been sent to see me by neurosurgeons for consideration of spinal surgery, and she was a lady, again in her 80s. She was overweight, she was unfit. And she could have had surgery, but I put a package of care around her, and 3 months later she'd lost 10 kilograms, she was going to an exercise physiology class regularly, she was much stronger, and it became much easier to actually change that no into a yes. So saying no is actually a very variable decision. And I really want to give you some language tonight that I'm starting to use around the decisions that I'm making with the patients that are being sent to see me. And I'm also going to talk a little bit about the discussions I'm having more and more around end-of-life care in an elective surgical setting. And finally, I'm going to leave you with my concept of teamwork, because I think teamwork is really critical to everything we do. And I want to talk about 3 geriatric syndromes and spend a little bit of time on them, because the 3 words I want you to take home from here to help you articulate that gut feeling you get when someone really doesn't look crisp. Those 3 keywords are frailty, cachexia, and sarcopenia. And I think frailty, Rob's actually given examples of how you can actually give people scores for frailty. The definition of frailty that I'm working with is 1 or more clinical systems at or beyond the threshold of clinical failure. And to me that's a lovely definition, because it's not just a bit of heart failure, bit of lung failure, bit of kidney failure. It can encompass things such as emotional problems. So people with severe depression, we know, do poorly. They can be accounted as being frail. People who have social vulnerability, who live alone, who don't actually have a lot of social support, who have poor health literacy, who have poor relationships with their GPs and community support services, they can also be termed as frail. And frailty is a predictor of increased length of stay, increased mortality, pretty much everything bad that can happen to you. Within frailty, I think the syndrome of cachexia is actually really important. And cachexia is really unintended weight loss in the setting of inflammation. And to me, it's really a sign of active catabolism, which is not being met by nutritional requirements. And I think Ivan actually said that albumin is a very strong predictor of poor perioperative outcome, which was outlined in the STORY study. And I think albumin, it's not a great marker of nutrition, but I think it's actually a strong marker of somebody who's in a highly catabolic state, who's likely to do more poorly. One of the other reasons I want to talk about frailty, cachexia and sarcopenia as these words are that once you start talking about them, I think they actually start opening up your mind to other methods of multimodal intervention in these patients. So if you're thinking about cachexia, you're kind of starting to think about nutrition. And perhaps you start thinking about how you can get a dietitian involved in the care of these patients to optimise them before surgery. Because sometimes saying no is saying, no, not yet. The other word that I think is really important is this word sarcopenia. And 300 years BC, Hippocrates described sarcopenia. He described wasting of the flesh from the clavicles, from the shoulders, from the thighs. This condition is fatal. Sarcopenia has been recognised for a long time as a description, but actually putting that word around it I think is really important, because again I think it actually starts opening you up to potential interventions around exercise physiology or physiotherapy. So I think sarcopenia is really important. And one of the concepts I have is the difference between fatness and fitness. I think of adipose tissue as a really active villain tissue. It puts out lots of inflammatory markers. It's associated with diabetes. It's a bad tissue. I think of muscle as being the superhero tissue in the body. It soaks up inflammation. It soaks up diabetes. And it's actually, the stronger you are, the greater your risk of, the better you're going to do with surgery. People who've been scored as being sarcopenic, they have a greater risk of falls, they have a greater risk of institutionalisation, and they have a greater risk of mortality. So to me, these three words are really useful at articulating some of the problems that we're seeing in the older, frail population, but also they actually start opening up possibilities for intervention. So one of the things that I think I'm becoming involved in is actually complex decision-making in surgery. And I don't think it's actually easy anymore, or maybe it is. Maybe you guys see all the easy ones and you just send me the hard decisions. But I get involved in complex decisions. And I'm going to take you through a real-life case. This is a woman called Madeline Dunham. Madeline Dunham was an 86-year-old woman. She had metastatic bowel cancer, but she was doing pretty well. It was thought that her life expectancy was probably going to be 12 months or so. Problem was that Mrs. Dunham developed severe crippling hip pain from primary osteoarthritis. She was on narcotics, she wasn't walking, she was facing institutionalisation because her quality of life was so poor. So I'm going to ask you to actually make a decision. Do you think this woman should actually have a hip arthroplasty or not? If you think she should have an operation, I'll get you to stand up. If you think that she shouldn't have an operation, stay sitting down. So, what are you going to do? I know it's nasty, isn't it? Okay. Now, I know that there's one orthopaedic surgeon in the room. Just before I tell you what actually happened with this woman, I'm going to tell you this woman is actually Barack Obama's grandmother. Does anyone want to change their decision? It's hard, isn't it? It's not a clear decision. You've got an elderly woman with a limited life expectancy, but she's in pain. It's not actually working. Oh. So what actually happened? She went on, she had a joint replacement. She died 2 weeks after her joint replacement. Was it a good decision? Well, Barack Obama was not unhappy with the decision. And I'm going to say to you, I probably would have said to her, I think it's reasonable that you have surgery. But I hope that I would have actually had a conversation with her about end-of-life care and palliative surgery. And I'm going to say to you, palliative surgery is not just doing surgery in a cancer situation where you have to do the surgery for quality of life. I think joint arthroplasty can be a palliative operation as well. And one of the things that I'm doing more and more often is actually talking to people and saying, have you thought that you might die with this surgery? If you do poorly, what do you want us to do? Do you want to be a piece of broccoli on a breathing machine? Most people say no to that one. But actually taking them step by step through, well, things might go wrong with surgery. You might die. You might spend a long time in ICU on a breathing machine. You might deteriorate 2 weeks after your surgery and we'd look at sending you back to ICU. Have you thought about these decisions? What would you want us to do as doctors if that situation happened to you? And really importantly, often a family are actually asked to come and attend the high-risk clinic. And I'll actually say, if you're not capable of making this decision, is there someone who can actually make this decision for you? Have you actually talked to your family to say what you would want if you're not capable of telling us, the treating medical team? And I think these conversations, it's really interesting. It's really frightening how many people go, oh, I haven't thought that I might die. You're 86 and you got cancer, really? It's frightening how many people said, oh, yes, I know what I want. Well, have you told your family? Oh, no. Should I? Yeah, I think that'd be a good idea. So it's really, I think these conversations, they're actually not that time consuming. They can be quite emotionally draining, but I think they're really important. And as part of this, more and more often, I'm actually starting to barge in on some of the subsequent surgical consultations to actually make sure that the surgeons and the patients are on the same page. Because I'll often say to patients, you might be okay with dying, but I'm going to have to sleep at night, and the surgeon who did your operation is going to have to sleep at night. And surgeons are not murderers. So actually really putting that burden back, not just making sure that the patients are aware that the decisions they're making, oh, I don't mind if I die with surgery, that's going to have consequences that are going to affect me as their treating doctor. So I think these decisions are really, conversations are really important. A couple of the other words that I've started using are in teamwork are the concepts of leadership and active followers. And leadership actually changes very often within a complex medical decision. And often I see my role is as an active follower. My job is to make sure, there's this word thaumaturgy, it's basically the science of the performance of miracles. So I get sent patients who are not well optimised and I turn them into miraculous 20-year-old marathon runners, apparently. Sometimes as an active follower, my job is to try and turn them into the 20-year-old marathon runner. But sometimes my job is actually to say, hang on here, I'm not being an active follower. I'm going to take a leadership role and say, stop, there's something we need to talk about. There's something more we need to do. So this is a Ferrari racing car. I believe it's red because red cars go faster. But I want you to think of the Ferrari as your patient. Now, you may have patients who are red Ferraris. Most of mine are rusty Holden Utes, but there you go. My concept is really of the surgeon as the driver of the car. But in this setting, the surgeon is not actually the leader. The leader is actually the person who's standing there with a stop sign, saying you're not ready to go yet. And when I think about teams involved in the care of this car, you can't get the right front wheel team actually changing the left back wheel tyre. Each team has their own special skill sets, and it's really important to value those, whether it's allied health, other medical colleagues, even other groups of physician subspecialists. Recognising their skill sets and valuing them is important. But also, if someone doesn't have a cardiac disease, you don't need to get a cardiologist involved. It's actually knowing what teams are around. And when we're dealing with the elderly, frail patient, the teams that I often use, if they've got cachexia, I'll get dietitians. If they've got sarcopenia, I'll get exercise physiologists or physiotherapists. If they're frail, I'll get a home occupational therapy review. So I have a very rich network of teams that I pull around me. Because one of the questions Rob said that I was going to answer, which I can't really, is whether we can actually make a lot of difference in preoperative optimisation of the frail elderly patient. I think the evidence is really lacking. But I think sometimes we can actually say no, not yet, and spend some time trying to get our patients looking more like the red Ferrari. Thank you.